Good morning to everyone and welcome to Montiar today. First of all, I would like to welcome all the applicants to our cardiology fellowship today. They are all following this lecture today, Mattia, and this is going to be a lecture about structural heart. It's a very interesting study, and hopefully you will learn from this. Mattia is our international speaker for today. He's of course, from Italy, is now currently based in Rome in Policlinico Gemelli, and he developed and published this study while he was doing his PhD in Verona with Professor Ribichini. So Mattia, please go ahead. Why don't you tell us about this study?
So thank you very much, Andrea, and thanks for this very kind invitation for presenting the result of this interesting study, the ICARO study. I want to thank also the institution that indeed supported the development of this study, in particular the University of Verona, where I spent my PhD and residency years, and also the University of Galway, where I spent my fellowship years, and that was one of the centers that was involved in the study. So what is the ICARO study? This is a trial aims at investigating the IVO's role in the assessment of the risk of obstruction, of coronary obstruction after TAVR. So you know maybe better than me the background of this topic, but I want to remember you some data just to emphasize the rationale of this study. In particular, we know that, of course, this is a particular complication occurring in valve procedure, but also the native valve has a kind of risk of coronary occlusion, despite very low. Despite the low rate and low incidence of this complication, this is a catastrophic one. So we have, in particular, when the operators cannot revascularize the patient, a high rate mortality at 30 days. So this is something that we need to prevent, or we need to promptly treat. And over the years, thanks to the multiple studies and registries on this topic, we identified the situation, the anatomical settings where these complications may occur more frequently. And in this vivid classification that stems from the vivid registry, actually, we can easily visually appreciate which are the patients that are at higher risk of this complication, in particular those that present a leaflet height over the coronary ostium height or over the STJ height, and this is in relationship also with the width of the sinus of Valsalva. So the interaction between these factors that are listed in this table are actually very important to be identified before a TAVR procedure to understand if we have a higher risk of coronary occlusion, in particular in patients that undergo a valve-in-valve procedure. We have to know which is the bioprosthetic valve that was implanted years before, because some of them, in particular those with an external leaflet or those stentless valve, are more at higher risk of obstruction. And then all the patient that present very low coronary ostia or a very effaced sinus of Valsalva, and a virtual transcatheter coronary distance or virtual transcatheter STJ distance can be a higher risk of this complication. So after having identified this patient, we have to do something, and in these patients we can perform different technique. Mainly two of them are the most, of course, implemented in the clinical practice, and these are the chimney technique and the basilica, but we will talk more about chimney because this study was focused on that. But in the result of the study, I will also highlight some results about chimney, about basilica, because some patients also were included that underwent basilica. So in the chimney technique provides for actually a protective wire and an undeployed stent in the coronary that is considered high risk for obstruction. That is a life-saving complication when we have an acute obstruction, meaning that once the valve is in place and we have a sudden occlusion of the left main on the right coronary, we just retract our pull back our stent and inflate these in this funny position that is called the chimney, creating a channel for the blood to flow into the coronary, even if the displaced leaflet of the old valve is against the ostium. But all those time when we don't have an acute coronary occlusion, actually, this is the real limitation of the chimney technique, because most of the stents that are placed in this position because an impending coronary occlusion, or because of the fear of the operator that, according to angiography, thinks that there is a high risk of occlusion, or maybe just because he doesn't know, this patient will have several drawbacks. In particular, if we place a stent in this position that maybe is unnecessary, we will have a lot of difficulties in coronary re-engagement, because it's practically impossible to get there again. And in case of ACS in the future of this patient, this is a very real challenging situation. Then we may have stent complication. In the chimney registry, after 2 years, they reported 5% of stent-related complication, among them stent thrombosis and breast stenosis, because, of course, a stent placed in this position is not natural, and the risk of stent complications is higher than a normal stent normally placed into the coronary. So this to say that we have to really know when we need to place this stent in absence of acute occlusion of the coronary. And at the moment, or at least at the moment of the beginning of this study, we only had angiography, but angiography sometimes is unreliable, because we may have a good coronary flow after angiography, after the THV, but because of the coronary wire in place that is, of course, protective, we may still have enough space for the blood to flow into the coronary, reassuring the operator about the patency of this ostium that actually, when we remove the wire, because reassured from the angiography, is suddenly occluded. This may happen because the protective coronary wire pin off the old leaflet that is displaced against the ostium, so keeping the coronary somehow open. So this is the real rationale of the ICARO study, because we wanted to look for something more that can tell us the truth. What happens in reality when we place the TAVR and the new interaction between the new valve, the old leaflet, and the coronary ostia are there. So we thought that HIVUS could have been a good tool to do this job, because through the HIVUS assessment of the coronary ostia before a chimney stent, in case we don't have an acute occlusion, may help the operators detecting some sign of the displaced leaflet against of the ostium, or the absence, guiding the operators or helping the operators deciding to put or not a stent. So this study actually stemmed from 2 previous small registries, but that were about the same concept, one from our team and one from your team, that actually investigated the same concept in a complementary way, and we can also discuss about this. It was designed as an observational multi-center study involving high-volume centers with experience in valve procedure, with experience in high-risk cases of course, coronary obstruction, among them Verona, Galway, Leipzig, and Toulouse. With the aim, first of all, to assess the feasibility and the safety of this kind of assessment, because it's not obvious that we can advance an IVUS catheter between the new valve and the aortic wall down to the coronary with the old leaflet displaced against the ostium and so on, without any complications. So this was our first aim. And secondarily, we wanted to, but not less important, we wanted to know if with an IVUS assessment we can spare some maybe unnecessary stent that, for example, in the chimney registry amounted at 60% of cases of patients stented because of a probable impending coronary obstruction that was not certain. According to that, we investigated the agreement between the HIBUS and the angiographic images that led to the decision to stent or not to stent. And we tried analyzing these images to understand if there was any marker, any predictor of that supporting the decision to stent or not to stent. And eventually we looked for, of course, the follow-up of the patient 1 year, in particular comparing those patients that underwent chimney stenting versus those not. So the study provided for a systematic and a specific procedural outline. In particular, the patient had to be protected with a coronary wire and an undeployed stents. And Basilica was also included in this registry because we wanted also to understand if IVUS could help the operators understanding the efficacy of Basilica. You know that Basilica in 5% of cases can be ineffective because we may have the post of the hold valve a little bit misaligned and close to the ostium, so our leaflet can be cut not exactly in front of the ostium, and we may have still a portion of the cut leaflet in front of the ostium. So we want to know if IVUS could also help in this situation. After that, we performed TAVI, and in absence of acute coronary obstruction, the operators were asked to perform an angiogram and an IVUS of the vessel that was considered at high risk, with the aim to evaluate the ostium patency, the presence or the absence of any sign of the native or the degenerated surgical leaflet close to the ostium. And in case of a Basilica case, indeed the presence or the absence of a portion of the cut leaflet in front of the ostium. Of course, not having any data about this kind of assessment, we left the decision to stent or not to stent to the operators based on their evaluation of the angiograms and the IVUS images. And then we offline evaluated these images in order to measure something and to understand beyond the classical and standard measurement of the diameters and the area of the coronary, what we can see at HIBUS and what can be measured. So one very important step of the study was also the post-chimney HIBUS assessment. In case of the chimney stent, because of an acute obstruction or because of the decision to stent after the HIBUS assessment, we recommended also to evaluate the stent with HIBUS, because most of these stents we found are basically deformed and severely underexpanded because of the presence of the leaflet pushing against the stent with a higher force than the radial force of the stent. So most of them needed a post-dilation. What about what we measured on the angiographic and HIBUS images that we got from these patients? From an angiographic point of view, actually, we looked for the presence of any image that was suspicion for leaflet prolapse or the footprint of the leaflet in front of the ostium, like in the left panel. Then we performed some QCA to understand if the stenosis was critical and just to get some measurement that can be associated with the decision to stent or not to stent. And in case of evidence of sinus sequestrations, we measured also the presence of the leaflet in that position. Regarding HIBUS measurement, we analyze, of course, the ostial dimension of the coronary. In this case, was pretty patent. Then, after just outside from the coronary, we tried to assess the presence of the leaflet footprint against or close to the ostium, like in this case. And in absence of a clear image of leaflet footprint just aside from the coronary, but when its appearance was quite far from the ostium, we measured the distance between the ostium and the appearance of the leaflet using the automatic pullback frame counting. We also tried to measure the residual cross-sectional area between the leaflet and the aortic wall in the paraosteal space to understand if the residual area was somehow associated with the decision of the operator to stent or not. And in case of chimney stent, we analyzed the eccentricity and the expansion of the stents before and after the post-dilation to understand how important is this step. So the 4 centers enrolled 40 vessels in 32 patients. All patients underwent coronary protection and undeployed stents, and 2 of them presented sudden coronary obstruction, so they underwent emergent chimney stenting. So we were able to perform the IVUS assessment in 38 in the 38 remaining vessels, and 9 of them underwent basilica. So in 100% of cases, the operators were able to advance the IVUS catheter, some of them through the jail catheter, others, but the minority, through an orthotopic catheter placed inside the valve and without complications. So this was a first very important finding. And the majority of the vessels, 2/3 of them, 24 vessels, were considered not to be at high risk of occlusions because of no specific sign or potential sign of occlusion at the IVUS and the angiography assessment, while in 14 cases we had to place a chimney stent, and I want to specify that the 2 of them had basilica before. So among the procedural data, as I said just before, the stent optimization was one of the results that was quite alarming, because 63% of these cases required a post-dilation to optimize the stent expansion and also the stent shape, because of the presence of the leaflet that pushing against the stent creates a sort of elliptic shape of the stent itself. And this is a very important element and point. Indeed, among the 14 patients that actually performed a chimney stent because of clear or doubtful signs of obstruction, 5 had actually normal angiographies. So this is very, very important, because underline the inaccuracy of angiography in understanding what really happened during in real time after the THV implant. Among the parameters that we tried to measure from the images obtained from angiography in IVUS, actually none of the angiographic parameters and measurements that we have done were associated with the decision to stent or not to stent, meaning that the operators actually relied more on IVUS than angiography. Indeed, all the IVUS measurement that we have performed were somehow associated with the decision to stent this or not to stent these patients, but actually none of them resulted an independent predictor of that, probably because it's more the interaction between these parameters, these measurement, or these it's simply visual elements that help the operator to decide the stenting or not this patient. Clinically, these patients were followed up to 1 year, and the patient actually that were not stented performed did very well, because they had a comparable outcome in terms of survival and also cardiovascular event compared to those that underwent a chimney stent. In particular, we didn't record cardiac death or MI due to probably stent thrombosis or problem or a delayed coronary occlusion in the deferred patients. And this is very important because it assures about also what we look during the procedure at IVUS that is somehow reliable also on the long term. So concluding, I want to underline these 5 key aspects that we should take home message. First of all, angiography can be considered an accurate tool to evaluate the ostium patency after a THV TAVI procedure when we have a high risk of coronary obstructions. IVUS looks feasible and also safe in this setting. And 2/3 of the chimney stents that were assessed. Sorry, 2/3 of the patients that were assessed actually were deferred after IVUS assessment. This means also less stent complication. Among them, not only the stent thrombosis and the restenosis that we mentioned at the beginning, but also shorter double antiplatelet therapy. And IVUS was useful also to evaluate the efficacy of basilica cases. 2 out of 9 patients in our series actually required a chimney stent because the cut of the leaflet was not effective. And eventually, the comparable outcomes between deferred and stent patients reassured about the long-term safety of this tool in this setting. Thank you very much. And anyone has questions, of course, is welcome.
Mattia, thanks so much for this lecture. When we saw this study with Azim Latif, we were very interested in hearing from you because this is actually reflects our clinical practice. All the cases of high risk of coronary obstruction, we do perform IVUS, as you showed. Azim published on this already with the first registry with delayed coronary obstruction, and also the technique, which is, I think, different from the one you showed here. That's why I wanted to ask you about this, because we, as you correctly said, even Basilica and a couple of weeks ago, even with the Unicorn, we still had to implant a stent. But I don't remember the last time we did the chimney, to be honest, because we usually re-engage from, inside the valve with another guide catheter, and then we perform IVUS from there. So even if we stent, let's say, from the left main into the sinus and the valve. When you were performing IVUS in this study, was this with the first guide catheter, or were you re-engaging? Was this done?
So thank you for your question. And yes, indeed, the protocol of the study provided for the assessment with the gel catheter. But actually, during our clinical practice and also the study itself, we tried many times to do that with a catheter inside, a second catheter inside the valve. And in case of needs of stenting, we perform an orthotopic stenting that is much better from also our engagement point of view, and I mean also for the shape of the stent. So we changed our practice also during the study. I have to say that 10 patients of the 10 vessels out of the 38 that were assessed with IVUS were assessed with the catheter inside the valve, and 6 of them were stenting in an orthotopically position that is much better. And also at the IVUS assessment after the stenting, we observed much less under expansion compared to the patients that had a classical chimney stent.
Yeah, I think that's a really important point, Matteo, because I think they both called gel stenting. I mean, I'm sorry, they both called chimney stenting, and I'm not sure then what the right nomenclature is. I like your, orthotopic versus, I guess, heterotopic, but when people think about that terminology, it's the terminology they think about for valves and for transplantation and so on. I've not thought about it for stents, but it kind of makes sense. So we've just, in our daily practice, we talk about a gel chimney stent or a normal chimney stent. But I think it's important because most of these cases, the patient is not obstructing at the moment, right?
Exactly.
And so we leave the jail guide until we can re-engage from through the stent struts so that we can recreate an ostium per se. And I think you mentioned all the great advantages of doing it. The one thing we didn't notice, because when we first started doing this, in a few cases, we did the IVUS from the jailed guide catheter, and we did an IVUS from the guide catheter that was placed normally. And there were a couple of cases we actually ended up stenting because the imaging was different. And the
Okay.
imaging was more concerning when we actually were inside the valve and did the IVUS. So I think there's a difference, but again, it's small experience. I'm not really sure you can make any conclusions. The one thing I think, and I'm glad you guys published this paper, because we feel as strongly as you, is that angiography just doesn't give you all the information, right? And you say that in your first note, your first key point here is most of the cases we've stented, there's the obvious ones where you see like something floating in the left main because some of the leaflets prolapse into the left main. I mean, that's obvious.
Yeah.
But there have been a lot of cases where we look at it and it looks good in angiography. And then when we do the IVUS, we see that, part of the leaflet is displaced or positioned in a way that the actual residual lumen there is very small. And so we've stented it, particularly because of the experience in the paper we published in JACC on delayed coronary obstruction, where there were cases where angiography looked fine, and then 3 or 4 days later, the patient was having ST elevation or having an acute MI, and many of those died. So again, congratulations. Um, I know you've been working with
Thank
Darren
you.
also on longer term outcomes of chimney stenting, right?
Yeah,
I
exactly.
think that's important too, because I think there's a risk we kind of, Basilica and Unicorn are interesting, and they're good procedures, but I'm not so sure they are generalizable. All right. So just for like the fellows, sometimes when we're worried about the old leaflet obstructing, we can either slice the leaflet and cut it in half so it opens like a curtain. That's called basilica, or we can do another procedure called unicorn, where we actually inflate the balloon in the leaflet and we blow up the leaflet. Um, so, both of those are getting, you see more papers, more people talking about it, but I can tell you now it's not generalizable. I think, and I also think some patients can't tolerate it, right? I mean, we've had poor outcomes in patients because we were trying to do basilica and the patient was just getting lots of AI and their ventricles can't tolerate the AI. So I think
Yeah.
sometimes just accepting that you're going to chimney stent is okay. It's not a bad thing if you do it properly, if you do IVUS, if you make sure, like you said, the stent's well expanded and well implanted, I think you can still get really good long-term outcomes with chimney stenting if well performed. But maybe you want to long talk from you. I'm trying to get to some of your experience with chimney stenting, and maybe you want to share with everybody because a lot of people see chimney stenting as this horrible bad thing that if you do a chimney stent, the patient is going to thrombose or definitely get restenosis. Do you want to maybe share some of the other data you're working on?
Yeah, thank you very much for all your comments that are very, very important. I think they are messages that need to be shared with both the young colleagues that start their training and the older colleagues that maybe are much experienced. So yes, about the chimney stents result, I'd say that we performed many CT scan as a follow-up to this patient, and actually only those patients that had some stent deformation and under expansion and then underwent also an angiography presented actually some stent issues such as stent restenosis or some subclinical thrombosis sometimes not actually inside the coronary but in the portion of the stent outside in the sinus of Valsalva. Otherwise, all those patients that actually had well implanted stent, in particular those in this so-called orthotopic way, or I'd say snorkeling, maybe. We have different names, different terms to describe this technique. They did better and had better outcome as well in terms of finding some angiography and clinically speaking. So what you said about the implantation of a chimney stent if implanted in a good way, if maybe assessed with HIVUS to expand it better, optimize its shape, it's really fundamental to get the best result for this patient that most of time don't have an alternative, and this is what we can do at our best. So I think this is very, very relevant.
Right, thank you. And congratulations on this paper.
Thank you very much, Professor Atib.
Thanks again, Mattia. Let's ask the audience and the discussants here if they have any questions. Maybe I'll start with Pierre and then we'll follow with the others.
Yeah, thanks, Mattia. Couple of questions. Did you it wasn't very many patients, but did you actually see any kind of delayed coronary artery obstruction in any of these patients? I know that fortunately incidence is pretty low. I'm just wondering if regardless, you think that this kind of technique can actually help us also, as Dr. T was saying, to actually capture those patients, and maybe they would not obstruct also right away, but then maybe after delete the cath lab, they may actually obstruct eventually. And one more question is, there were a couple of cases, I think, with basilica that still required chimney stenting. So I'm just wondering if among the 9 patients with basilica, when you compare the 2 that required chimney stenting versus the 7 that didn't, if you notice any kind of pattern, so that maybe, it's some kind of anatomy is, you need to be ready after basilica also just to, just be ready for a chimney.
Yeah, thank you for your questions, Pierre. So about the first one, in our series, we didn't have a delay obstruction. In particular, unfortunately, we had one large MI, left MI, because of stent thrombosis of one chimney stent that actually was not optimized. The patient had an acute occlusion, so the operators placed the stent very quickly, and then maybe in this kind of acute setting, they did not optimize the stent or check for the best result. And after one day, the patient had a large MI and died because of probably this, because we are just hypothesizing what happened. About the basilica cases, one of the 2 cases had actually a misalignment of the old surgical valve that had actually a post, not just in front of the ostium, otherwise we didn't think about basilica, but it was like 30 degrees from the ostium. So it was expected that the basilica could not have been effective, and we also were prepared to place the chimney stent. In the other case of basilica, actually, we didn't expect such result because the old valve was aligned, and we had good space in the mid of the leaflet, but actually the puncture of the leaflet was not very clear and probably didn't get the mid of the leaflet. So actually at the HIVUS we had a large footprint close to the ostium, and we preferred to place the stent.
Thanks. No, absolutely. I agree. I think sometimes, even when you're lacerating with basilica, I mean, it's not controllable to 100%. So I agree with you, and IVUS is always very useful, I think, even if a successful basilica, just to confirm the result. Thanks, Mattia.
Yeah, and indeed in the paper we published the one image about the basilica case, about this of the misalignment valve, because it's very important to understand even when basilica wants to be tried or not.
Thanks, Mattia. I see we have another question from Andrea Mignati, who is our Cath lab director. Andrea, please feel free to ask your question.
Yes. Hi, good morning.
Yeah.
Thank you very much. Great study, great presentation. Couple of questions. The first one is, how are you evaluating the stent size and the length when before the TAVR? Do you IVUS before the procedure? And then based on that, if you have any recommendation on the stent type, any stents that you particularly use with radial force for this kind of a procedure. And then the last question is, I was reading your article, very, very well written, is on the supplemental, you're describing a technique with a 7 French guide where you're actually using 2 wires. One is where you have your stent, and the second is that the one where you could actually use for IVUS. Can you expand on this and whether it has any utility of just putting 2 wires and going in in order not to have to retrieve the stent and then replace it again?
Sure. Thank you very much for your questions. So about the assessment of the sites, the stent dimension, actually, we usually use the CT scan pre-TAVI. So we used to measure the length of the left main to the bifurcation and, of course, the diameters. And we get a longer stent than the length of the left main stent in case of left main. In case of a right coronary, depending on also the presence of atherosclerotic disease in the proximal segment of the coronary or not, but we try to keep at least 5-10 millimeters longer than the dimension we would select in case of a normal stenting up to the ostium. And we also not recommended, actually, we talked about that when we wrote the protocol. We wanted to assess IVUS also before TAVI in these patients, even to better understand what was already there before the THV implant and what happened after. Actually, it was done only in 5 patients, and in those patients that was done, we got, of course, good coronary results for the stenting implantation in case of chimney stent, but we didn't find we didn't get great information about the position of the leaflet or so we thought it was quite useless, and we just not recommended. We didn't recommend to do that in the protocol. So it was done only in few patients in our center in Verona. What about the stent radial force? We use all, can say here some stent name, actually Medtronic and Abbott stent. We thought that they were the stent that gave us more results than the others, so actually we were more confident with them, and honestly we didn't try other type of stent. I think they performed quite well. And actually I forgot your last question. Oh yeah, about the 7 French catheter. So this was a technique that was thought because of the fear of not being able to advance the IVUS catheter, the stent after the IVUS assessment. I mean, if we don't have an acute coronary obstruction, we maybe are able to advance the IVUS, perform the assessment, but sometimes with the gel stent, with the gel guiding catheter, can be a little bit tricky to advance the stent in case of need of chimney stenting. So this was developed or just thought to avoid this difficulty. Having 2 wires down to the coronary, over 1 wire, you can just have the parked stent ready for the chimney stent, and on the other wire you can perform the IVUS assessment. But since we started to use also the second catheter inside the valve to perform the IVUS assessment in absence of acute complications, this technique was never actually used except for 1 patient at the very beginning of the study. And I think that with in case of hemodynamic stability, and we have time to place, as Professor Latib said, a second guided catheter inside the valve. We don't need the 7 French gel catheter with 2 wires.
Thank you.
Thank you.
Thanks, Mattia. The next question is from Osama El Said, who is our structural fellow for this year. Osama.
Can't hear Osama. Maybe you
Osama,
can.
we cannot hear you.
Not yet.
If you can write it down, Osama, if you have troubles with your microphone. Yeah, he's writing the question right now.
Perfect.
In the meantime, we can ask Gianmaria. Gianmaria, do you have any questions for Mattia? All technical issues today. So Osama is asking, this is for all of those who cannot access the chat, what are your thoughts regarding accessing the left main after chimney stenting?
My thoughts are that is actually not impossible, but quite impossible. I mean, I remember one case that where we tried to recannulate the left main after placing a chimney stent with an evolute valve, and actually we had to cannulate it with a multi-purpose guiding catheter and a telescope inside. So it was not easy, of course. It was done by a very expert operator, and we got a kind of selective cannulation just in the portions outside from the coronary between the valve and the aorta with the telescope extension catheter. But I think it's really tricky. And also, I want to know your experience about that, but because we actually didn't have so many cases where we had the opportunity to, maybe luckily, to recannulate these stents. But I think it's very tricky and also very dangerous, because you can just destroy the stent or push the stent struts against the valve strut or the aortic wall, so creating some deformation again that it can be very, very dangerous in the future. What do you think about that, Andrea or Professor Latib? Did you have experience on cannulation after chimney stent? I mean, in
Yes.
that position.
So Andrea's going to tell you, because I think he did one recently on a patient. But it can be very challenging, especially if you jailed it. It can be almost impossible.
Yeah,
Well, not
indeed.
impossible. If you jail it, then you have to create a new osteum, right? So you have to end up going through the stent struts, dilate the stent struts open, and then re-stent to recreate an osteum. But it can be extremely challenging. So you want to do as good a job as possible in the beginning to try not to have to re-access it. And it's kind of why I just like the jailed chimney stent, because it's, you can't re-access the jailed chimney stent through the proximal part of the stent. You have to go through the side of a stent and recreate a new ostium, in a sense, and a new chimney. But Andrea, didn't you just do one recently, one of our patients who we did a basilica end stenting on?
Yes, yes, it was like 3 weeks ago.
Yeah.
It was this patient treated by Azim actually last year, exactly 1 year ago. It was a case with basilica. It was a very very difficult, challenging case, despite basilica required this chimney stenting. The valve was an Evolute FX Plus, so we knew the valve the commissures were well aligned. which clearly helped. And then Azim nicely placed these two stents in both the RCA and the left main ostium in this orthotopic way, as you said. And I think this helped a lot. Because re-engaging them actually was not as challenging as I would have expected. So just like with the JR4 guide for the RCA with the wire and an EBU 3.
And did the patient have restenosis at the ostium or more distally?
So more distally, actually.
Yeah, not at the ostium, which was interesting, right? Because this was a patient also on dialysis with chronic kidney disease. So, you know, what I found interesting about the pictures, Andrea, correct me if I'm wrong, it wasn't like at the ostium, so it wasn't the chimney part, it was actually inside the body of the coronary artery.
Yeah, absolutely. Yes, it was like the RCA was, the ostium was spared, was okay, as well as the part of the stent protruding into the sinus, into the valve. And then the proximate RCA was a CTO when I checked. And the problem, which is the reason why she came with an NSTEMI, it was the LAD actually. So the stent from the left main was okay until the ostium of the LAD with a 95% restenosis. And it was very interesting that, as Azim just said, like all the more proximal portion was actually free from disease, but it was like in the ostial LAD in this case, rather than the left main or in the sinus space. So clearly, as you said, I mean, the experience is very limited. There are very few cases, and if probably it was difficult for you to collect all these cases, I think it's going to be even more difficult to collect cases with re-access. Maybe in the future, when we will be doing more of these procedures, maybe we will have more cases, and maybe you can do another registry, Mattia.
Yeah, it would be great to collaborate on that and have more cases together.
Let's see if we have other questions here. And if Gianmaria or anyone else from the chat, if you have any questions. Otherwise, we can, I think we discussed a lot. It was very interesting. I see Azim, like, yeah, you turn on your camera.
No, just to say goodbye once you finish.
Okay, no, I just wanted to thank you again, Mattia. It was like really a brilliant study, first of all, and also this lecture we all enjoyed, and hopefully many people will start using this technique, which is very important. I would like to wish good luck to all the applicants to our cardiology fellowship today. Good luck with your interviews. Hopefully you enjoyed and you like this lecture. And Mattia, thanks again. Thanks so much for being here today.
Thank you, Andrea, and thanks. Thanks, Professor Latib. It was very interesting also to meet you and know your experience about that. I think it would be really great in the future to share some data and maybe have more knowledge on this topic.
Absolutely, we definitely have to collaborate in the future, Mattia. Keep up the good work. Keep on publishing and continue with your research, and give our best to the rest of your colleagues. And again, good luck to all the cardiology fellows. Thank you for considering Montefiore as one of your top choices. Take care, everyone. Bye-bye.
Good luck to everybody. Bye-bye. Have a nice day. Bye.
Bye.